All right, everybody, we're going to go ahead and get started. Welcome to Medical Grand Rounds at the University of Colorado. Really happy to see everyone here in Krugman Conference Hall. We are going to continue to broadcast this remotely via Zoom, but I really am encouraging everyone to come in person, both for the talks, but also for the community as the year goes on. As a little bit of a teaser, next week, do not come in person. So on September 13th, this is the first of our 4 quarterly Department of Medicine Systems Improvement Conferences. We will be presented by Drs. Katie Raffel, who's in the Division of Hospital Medicine, and Alex Grubb, who's a cardiology fellow and one of our medical education fellows this year. This is an all virtual talk, so next week is all online. But we are back in this room on September 20th, and we'll be welcoming Dr. Josephine Chow from the Division of Cardiology, who will talk about the emerging and really fast-changing field of cardio obstetrics. As a reminder, all talks this year are eligible for CME and MOC credit. Hopefully you went ahead and scanned that already. Questions will come from our live audience primarily, but the chief residents, thank you for watching the Zoom Q&A. If you are watching this online and you have questions for Dr. Pearson, please feel free to put them in the Q&A feature. Now, I really am very pleased to welcome today's speaker, Dr. Duane Pearson. Dr. Pearson is a professor of rheumatology here at the University of Colorado. He is the recent past associate chair for clinical practice, as well as practice director in the Division of Rheumatology. And related exactly, or more specifically, what he's going to talk about today, he is also the medical director for the Peer Mentored Care Collaborative, as well as the medical director of ECHO Colorado. He did his undergrad work at Lake Forest College. He was a medical student at UC Davis. He did his internship, residency, as well as fellowship here at the University of Colorado. Dr. Pearson is widely recognized for his innovative and thoughtful approach to care delivery, as well as both clinician and patient education. He was awarded the 2021 CU Innovation Efficiency Award for electronic consults, as well as the 2020 Department of Medicine Innovator Award for his virtual health education platform. He currently serves as the Department of Medicine e-consult operational leadership group and pediatrics care transitions group through the Children's Hospital of Colorado. His work in care delivery and education has been funded by a matching grant from the Chancellor's Office at the University of Colorado, the Peer Mentored Care Collaborative in the School of Medicine, as well as an AHRQ ECHO National Action Network funding source. It really is a pleasure to welcome today Dr. Duane Pearson to talk about right-sizing care, a peer-mentored care model.
Thank you, Jeff. It really is a unique honor to stand up in front of so many people that helped train me coming back from my internship and onward. I still feel like the schlub that people trained down at Garfield Clinic when that was a part of the training program. So if I seem a little bit taken aback, I am. It's a great honor to be here and talk about the work I've done over the last 10 years. After fellowship, I had moved out to California, where I served as a medical director for specialty services for a county program, and then came back in 2013 with a specific goal of to try to figure out how we can integrate other modes of care delivery in terms of leveraging the outstanding specialty panel we have at the university to try to meet the needs in rural and underserved Colorado. So that's my spiel. At the end of today, I hope you can recall those different levels of care delivery that are peer mentored in nature and understand the definition of that, how this work fits into a value-based construct, and then also look at case examples where this is applicable and where we have data, but then also hopefully stimulate you to think about how these tools that we've developed and continue to grow on campus can be used to expand the impact of your work and your research. I have no disclosures. So this came out in 2005. I was a fellow, and this explains exactly the work that where my work has taken me. In 2005, there was an American College of Rheumatology workforce study that said, hey, at this time, we actually have about the right number of rheumatologists, supply being the blue line in 2005, demand being the yellow line. But casting forward in 2025, we're going to run into trouble. In fact, we were going to have a pretty significant gap of about 1,000 rheumatologists by 2015. 2015 came and went, and they were right. And that impairs patient care. But worse yet, nothing had been done. So by 2025, and that seemed like a long time ago, now it's here. We actually have a shortfall of at least 1,000 rheumatologists nationally. if you take the assumption of business as usual. But projecting that out even farther, we're getting into some serious straits. Now, this is also a regional impact, where you can actually look at the Rocky Mountain West, Desert West. Typically, the number of rheumatologists you need for a population is somewhere between 60 to 70,000, one rheumatologist for 60 or 70,000. And that's business as usual, right? Seeing everybody that gets referred to a rheumatologist. Currently, 2015, we have about a little bit understaffed, but able to make by. But by 2025, sorry, in 2015, we're okay. 2025, we have a massive shortfall in this area. This is true for the Pacific Northwest. This is true for the Midwest. The areas that we don't see problems are actually in the Great Lakes area, the Eastern Seaboard, and California. This is not exclusive to rheumatology. That slide is what brought me into this work, but this is actually true across most specialties as well as primary care. This is data from the AAMC that's saying by 2034, we're going to be up to 124,000 shortfall in physicians nationally. That's a huge issue. This is actually, if you look at medical utilization patterns and say that if everybody in rural America were going to get care the way that we do in urban centers, that number actually is higher, around 188,000. The gap in PCPs is about half of that. Non-primary care specialists, and then surgical specialists. We're seeing the retirement wave, and this is actually all research that was done before the COVID retirements. So before COVID retirements, we're seeing 2 out of every 5 physicians reaching retirement age, and now people taking retirement earlier. Furthermore, there's an asymmetry of distribution. And part of that is necessary and structural, and I'll get into that, but part of it as well is just based on where people want to live. When we look at the demand, and I feel like when I think about medical demand, it's why we do this. We want to have patients come see us. We want to ply our trade. We want to care for people. Population growth up to 363 million, 10% per year. We are seeing an aging population, and now we're seeing an increased frequency of chronic disease, where 6 out of 10 Americans have some form of chronic disease that needs management. Now, there is good news that the number of training slots have been increased. I think Jeff is more on that, but the 2021 Residency Funding Act actually is increasing residency slots over the next 10 years. However, there's going to be a time lag in training. So if you want to train a rheumatologist, that's going to be 3 years of residency, then 2 or 3 years. So that's a 5-year lag. If you want a neurosurgeon, you're talking about a 10 to even longer time lag in that training lag. So again, there are people that are going to be coming through the residency in the next 7 years, and by the time they're done being trained as a specialist, they're just hitting their stride in 2034. One thing that also is interesting is the idea of the amplification of care disparities is the rate of change of medical knowledge. And so in 2011, they projected that the rate of change of medical knowledge, the doubling is going to be every 73 days by 2020. If you've tried to keep up with COVID, I think we're there. But to put that in perspective, the rate of medical knowledge doubling in 1950 was 50 years. By the time we got into the 80s, the rate of doubling had come down to 3 years. 73 days. How is anybody that's practicing primary care medicine actually supposed to be able to keep up with that? It's very challenging. So this is felt greatest in rural America, and that's 15% of the population. If you live, there was a great article here out of this program that actually showed if you live in rural Colorado, you're more likely to die from your lung cancer in case-controlled studies. But it doesn't stop there. You're more likely to die from heart disease, unintentional injury, chronic respiratory disease, stroke. If you live rurally, you're just not going to live as long, statistically. So the increasing complexities associated with chronic conditions require more specialized multidisciplinary medical approach. But you can't maintain a workforce in those areas. And actually, economically, in some ways, it doesn't make sense. There are hospitals out in rural Colorado that have 40 beds. It doesn't make sense to have somebody that is an expert in thyroid cancer there, or an infectious disease doctor. There are other structural barriers then. If you accept the idea of care in your home community in rural Colorado, there are other structural barriers. So there's the specialty shortage, geographic barriers and financial barriers. It takes time and money to come see a specialist on this campus. There was a study done at Children's. The amount of money that it takes to bring a patient up from Durango was the home community to be seen by our pediatric epileptic specialists. It took 2 days because, again, you had to drive up the day before to be available for the appointment. And it actually cost families out of pocket $700. And that's including travel, time, meds, and time away from work. It is not cheap, and there's no insurance that's paying those indirect costs either. So there's multiple structural and financial barriers. So to put it back into perspective, this is actually from the ACR in 2013, looking at geographic distribution of rheumatologists. The color you want is actually about that color there. That is 1 to 2 rheumatologists per 100,000. Now, again, this is 2013. We're no longer there. But the other thing that this article missed and this map misses is the fact that all these areas around here that are not metropolitan statistical areas, they have to get their care somewhere. And so those bleed into these, and showing that, again, we have asymmetry in our distribution of rheumatologists. You can do this across all of our specialties. It's going to be very similar. So again, the scope of the workforce problem, it has absolute ripple effects across multiple barriers to care, amplifying delays in care, amplifying delays in diagnosis, and eventually increasing the cost of care as well because somebody comes in with more advanced disease. Now, even in the best of times, referral management is challenging. And again, there's been articles after articles. This is the diagram that I like the best. Again, so when you look at a simple referral within your network, getting the data back to the primary care physician, having the primary care physician act on that recommendation is a 10-step process. There's going to be errors. And even with EHRs, some of those have been decreased, but there have been a number of studies that actually looked at that and said, it's not really taken, because if you've ever placed a referral in our EHR, you're trying to actually geolocate for the patient. What's the practice that's close to you? There's nomenclature in there that you're not quite sure. The number of people that we see with gout being sent to the CLB for our rheumatologist that specializes in lung disease, it's not small. So why do we talk? This gets into an esoteric discussion. Why do physicians talk? Part of it is commiseration. It's a hard job. You go home at the end of the day, family doesn't understand what you're going through. There's burnout. We talk because, again, we support each other and we're a community and we love each other. But part of it is actually collaboration. There are functional things that are embedded into our discussions that are very, very important we don't think about. Part of it is looking for logistics. How can I get you to see my patient, or who do you think my patient should see? Care transitions. You're going to see my patient. This is what I need you to do. This is what I'm thinking about. This is my agenda. This is the patient's agenda. That used to happen around the cooler in the doctor's lounge. It used to happen in an organic fashion. There's not a lot of data that actually says it happens well. But now in our harried time and when we're actually working in EHRs, that doesn't happen as much. In fact, we say, I think you need the specialist, I'm putting in the order. And if you put in an order, actually, that what your question is, you're in the minority based on national data. So we look for advice on and education. We look for treatment advice. We look for further diagnostic education. We know that this is fraud. And this doesn't even include talking about levels of care. How much I want from you as a specialist. Do I want you to assume a care for this problem? Or do I want to co-manage with you? Do I want this to be a one-time visit with advice? We have those buttons in Epic. I helped get those built in back in 2015 with Amber Saja. Nobody uses them really. I thought it was a great idea. So there is no way that we actually summarize, because down in this area, when you're consultant activation phase, that can actually have self-contained loops in there as well. And then if we're not feeling back or actually saying, hey, I'm seeing this patient, I'm taking care of their RA, but I really need help with their diabetes, those modes of communication are very challenging in the best of times. So more than a third of patients in the US are referred to specialists every year. That is way up from the turn of the century. That is way up. It used to be about 10%. So many challenges exist. And again, when you look at interoperability, you have to think about, is this a closed loop system like our Epic between primary care and specialists, or is it an open system where you actually are trying to still fax? What professions use faxes? At least we got rid of our pagers finally, right? I don't look like a drug dealer anymore. I mean, ever, Vinny. I've never looked like a drug, just a schlub. So then there's issues with transmission. Did your EFACs actually go through? Did they get it? Did they do anything with it? The number of referrals that we'll find in like secret areas in our Epic is not small. And then lastly is the clarity of the request. What is the agenda setting? Are people taking time to actually set the agenda, to communicate with that agenda, and how that might differ from the patient's agenda? As a specialist, I have to say my worst moments in healthcare, among my top 5, are when you come in the room, the patient has no clue why they're there. You have absolutely no data to frame the discussion. You have no clue why the primary has sent them on, and you're completely flying blind. And then you have an angry patient because didn't they send everything to you? That's a miserable point. That creates moral hazard. So going back to it again, should we communicate more? We should, but there's also data that was published out of Denver Health and our hospitalist team here that curbsides actually might be bad. They're not formatted. There's variable number of questions that are asked. And when they did a concordance study on this, and they found that there was low concordance in between what the curbside recommendation was and the final formal consultation is. Now the model, this peer mentored care collaborative, the idea was to bring together asynchronous and synchronous forms of communication that are highly formatted, that are specific to specialty, to allow and drive patients through their capacity to be able to work first on level setting. Do you need to see my patient? This is my question. Do you need to see my patient? Here is my data that's leading to this. And if you think I can manage this, tell me how to manage it. And that is the whole idea behind this. It is that simple. But recognizing also that there's technological challenges where doing an e-consult actually might be easier, doing it asynchronously, or versus carving out time and sitting in front of a web-based educational platform to review your cases. But it's the same idea. Let me talk to you about your care. Let me talk to you the way we used to talk in the doctor's lounge and figure out what the right level of care is for your patient. And in this way, again, these are our happy folks that are over here in the primary medical home. It's a happy place from my understanding. But specialty service is part of this, but how we can actually take specialty knowledge and help foster this relationship to be able to leverage other modes of care more effectively. So the criteria were that we need something that was bidirectional and iterative. You can come back and ask me a question. If things change, please come back and it is actually voluntary. If you think that your patient needs care, I will see your patient, but let's see what we can do first for that patient in your medical home. Then also hoping that we had increased efficiency of care transition. So the idea that, hey, you've invested your time to submit a case or an e-consult. What is the likelihood that patient's going to follow through? What is the likelihood you're going to follow through on care recommendations? We have answers to some of that, but not all. So the first question is, can we do this safely? And this goes back to the curbside study that said, this is probably not a safe way to manage. And again, I think the Division of Rheumatology takes it very seriously, where if you consult us, we're going to see the patient when they're hospitalized, period, because curbsides are probably not good care. However, if you look at a more formatted program, so we have done triage, referral triage in rheumatology since the mid-1990s. Sterling West and Vansbury were the first generation. I think I'm 7th generation, 8th generation, and doing rheumatology. And again, I'm glad nobody booed or threw a tomato because it's not well loved in any sense. But it actually does help address one thing, which is physical capacity. Providers in space, we have the capacity to see a half to 3/4 of the referrals that are sent to us. And that's a generous, the 3/4 is kind of generous, that are referred to the AMC, assuming current practice patterns, right? And that goes back to templating, about how you align your staff. But based on current practice patterns and what the standard of care is, there's too much demand, not enough supply. So in 2014, we actually looked, and this was led by Sterling West. We looked back at 9 months of referrals, and we had our typical, we were able to offer appointments to about 70% of those referrals. And what we found at the end of it, so we had follow-up on both the folks that were referred and had evidence of autoimmune inflammatory rheumatologic disease, and those that were evaluated by a rheumatologist and did not. But then we were able to actually look at about 44% of those that were not seen at a year's time to see, were there cases we missed? And yes, there were cases we missed. We missed 6. So if you look at typical lab testing, right, if you have something that has a 98% sensitivity and a 34% specificity, that's a pretty damn good lab test. If you go back at referrals and our capacity to screen referrals, that's a pretty good test. And it has low specificity, which is, again, explains why we saw 240 people with no autoimmune inflammatory rheumatologic disease. Specificity is set nice and low. Now, if we were to change the criteria that we're using, it works just like any other responder operator curve. So this is actually all of these. We typically have anywhere from 3 to 4 reviewers that do this work. We all follow the same rules. We're looking for inflammation on exam and documented exams. We're looking for a particular lab test. I won't bore you with it. But what, at the end of the day, it enabled greater than 200 time slots for patients with autoimmune inflammatory rheumatologic disease that otherwise would have been waiting longer. So how do e-consults and echo fit into a larger care framework? So again, I take that triage referral to be very similar to what we do in e-consults. You're going to send me a question, you're going to send me data, I'm going to review that, then we're going to agree on what a level of care is. And if you think that you can manage it and I think you can manage it, I'm going to give you my recommendations. That's closed loop. That's a completed e-consult. If you don't think that you're able to manage what's going on, you're not even going to place an e-consult. You're going to place a referral. If I think that there's more complexity here and I need to actually lay hands on that patient, that's going to be converted. We're going to bring that patient in. So when you look at this, again, if you start to say, okay, well, what does a healthcare spectrum look like if we were to add on these other modes of care delivery, where, again, I am part of your medical home. I'm part of your virtual neighborhood. We have our traditional in-person care, which is, again, its convenience is poor for patients. There's difficulty with population health connection because, again, population health connection is supposed to be occurring through the primary medical home, and we're moving people out of that. And that's necessary in a lot of cases. But there are also just as many cases where it actually might not be benefiting the patient. Now, over the pandemic, we all learned telemedicine, and it's absolutely something we should have been doing for decades before. To be able to meet a patient in their home or an outlying clinic for routine care, I'm going to check your labs. There are multiple cases across every specialty where that works great, and there's a ton of instances where it shouldn't be happening at all. I cannot do a great joint exam for somebody that has AS remotely. I've tried it. I can do a pretty good, I believe, joint exam for RA if it's only affecting them from the waist up. It's really hard to get somebody to lift up their foot and to look for synovitis in the feet, but synovitis is challenging in the feet anyways. So when I think about when you start looking then at e-consults and costs, and I'm going to take you through again, this might be a less costly mode of care delivery. Frequency is as needed because there's so few barriers to getting a patient in. Convenience is outstanding for both primary care and patient alike. And then because you're working with you're seeing patients in a more, or I shouldn't say seeing patients, but you're providing care at a more rapid pace, it actually does have a force multiplying effect. Same concept of bring me a case and let's talk about this particular disease. That's the ECHO model, which I'll get more into. But you can actually have 30, 40 primary care providers learning about that topic and able to present cases. So that has a huge force multiplier to be able to work and lift care remotely. So when I look at this and we talk about putting this into a value context, I really do, I'm guided by the quadruple aim. And if this is worthwhile, it should improve outcomes. It should reduce the total cost of care. It should improve the patient experience and the provider experience as well. So e-consults. We started in 2018 after we had done a small local pilot. Ann Fulbergy came in and helped us partner with the AAMC, which had already done 2 separate cohorts about launching e-consults. Now, these are typically embedded into your electronic health record. There are multiple core sites, and core stands for Coordinating Optimal Referral Experience. Love the acronyms. We were one of the first groups that actually launched pediatric and adult specialties at the same time. And now I believe they're up to they're enrolling cohort number 6 now. So this is taken off across multiple academic centers. We've been helpful in working with other academic centers in terms of training in rheumatology. So we still have a good working relationship with the AAMC. This is a messy slide, and I intended it to be I really didn't. I just suck at PowerPoint. But it really does reflect the challenges of interoperability. So again, you have to get your like Russell Crowe mind together and start pulling your yarn everywhere. So with the Affordable Care Act came out and said, hey, it's a standard to have EHRs. But at some point, we'll talk about how EHRs can talk to each other. And while that is still ongoing, there are federal departments that are focused on interoperability. We're still very, very far from there. So the core program actually is, as I said, typical for you have your specialists and PCPs within a single EHR, our instance of Epic. But what happens to primary care groups that don't have specialty alignment? Where can they do e-consults? How about a PCP? There's still PCPs out there that don't have EHRs. So the most common form of e-consult that's occurring now is actually PCPs without EHRs and EHRs that don't have specialist aligned using an internet-based e-consult platform. And so these folks can sign on through the web and submit specialists via the web. This group actually they typically can build out a single sign-on. So you can click, you're in the web, able to place your e-consult, and then it comes back to you via the web. These are unaffiliated specialists. And so in some ways, it takes away from the power that we were looking for in terms of level setting. What happens if I say, I think that this person needs to see a rheumatologist. They have a high titer CCP. You're seeing synovitis on exam. The standard would be to get that patient on methotrexate quickly. What if you're not comfortable with methotrexate? There's so many different steps down, and because there's no affiliation, that kind of leaves people out in the lurch. And so when we've been doing our program here, part of it is that, hey, if that e-consult can't be answered, we offer an appointment. And that's standard across most of our groups. So taking that though and expanding and saying, okay, well, there's so many affiliated primary care groups in the state of Colorado that don't have this affiliation. So we have Stride that's in our EHR. That's a great opportunity to do e-consults, and we do that for them. But how about the Salutes? How about the Peak Vistas that send us a ton of referrals that probably can be managed within their primary medical home? And so we actually helped partner with one of these internet-based e-consult platforms and develop what we call the external pivot that is now being adopted across other academic sites to be able to actually have a private company go and build in the SSO in their EHR and then communicate those referrals into our queues in a very similar way, not identical, but a very similar workflow as we have for our internal e-consults. At the same time, Steve Hess and our Epic group are going out and working with groups that are primary care groups, but using the Community Connect architecture that's in Epic, and so they can actually place in e-consults. That's been happening for quite some time. We don't even notice it because it is truly within our Epic, so it even though they're unaffiliated or loosely affiliated, they still come in through our work queue. So through that, the current reach of our program, these circles are actually our the initial range of our first core launch. UC Health has actually now aligned UCHMG to provide e-consults in their regions as well, which is very nice. But then through the external pivot, we have multiple FQHC partner networks that can submit e-consults. So that's the build out that we've had since 2018. Growth. Since inception, we've had 19,000 adult e-consults placed. We've had a great growth curve. Proof of principle. 76% of e-consults are answered. Those are patients that are managed in the primary medical home through peer collaboration and guidance. 16% are converted. I think this patient needs to be seen, we'll bring them in. 8% are declined. That 8% is the one, that's my pain point. That's the patient that is sitting in the room and you're like, I have no clue why you're here. I'm not a dermatologist. You know, that is the referral management. And now the patient's not even involved. If I say, no, wait a second, here Hashimoto's is typically managed through endocrine, or I'm looking at Mike McCall and saying, metabolic bone disease? No, up to endocrinology. They're great. So again, nice growth. These small bars are, again, the adoption that we're seeing across the FQHCs. And the truth is, it's a lot of sites, but they don't have anywhere near the number of providers that we have here. This is the e-consult growth for pediatrics. Very similar growth. We've had 13,000 pediatric e-consults. So what did we learn? So there've been over 540 different PCPs have placed e-consults. And that's a year-old data. 80% of them are physicians. If you're using them, you use them repeatedly. And then the majority of them are actually placed during normal business hours. It's not creating shoulder work. Specialty care providers typically can answer them in just over 10 minutes on average. But again, there are ones that take longer, but on average, and we actually did that based on billing hierarchy in the first 2 years. We're not tracking that anymore. Average turnaround time, about 2 business days, as compared to the typical wait time in clinic, is important. And then 78% of those are answered during the normal business hours. One exception to that, the volume seen in endocrine, which again has since the beginning have absolutely been the highest utilized group. They see so many e-consults. It was inhumane for them to continue to do this during business hours. So working with CU Medicine and hospital leadership, there are other ways now that they're actually having more protected time for this, because again, they see more than the next 3 groups combined. It's really what's happened in endocrine is amazing. PCPs have been satisfied. I'll just leave it at that. Again, we did those surveys during the first 2 years. We haven't repeated, but this is in keeping with what you see published in almost all other reviews of PCP satisfaction with e-consults. Now, we were kind of interested about what kind of downstream impacts was this going to have. Am I going to be doing e-consults and I'm going to be seeing the patient anyways, which actually then creates a complete loss of cost? That's ridiculous. And what we found was no. About 5% of patients seen with patients are seen in the corresponding specialties clinic within 30 days. So I place an e-consult, you end up getting booked and being seen 5% of the time. But it's only 2% of the same diagnosis as an e-consult. And as I've reviewed some of those, a lot of times it was actually the data that was generated based on the e-consult showed, oh, wait a second, it's a different problem, and yes, we should get that patient in. The other thing is that what we saw is that when you look at ED utilization for 3 months post e-consult, there's actually there's a reduction of 2.5% in ED utilization compared to a standardized group. I think that needs to be repeated, but I think it's a very important finding. Less resource utilization in the primary medical home. There's actually a 7% decrease in the use of any primary care services for 3 months afterwards. So when we talk about, is this just task shifting or work shifting? I think that there's an opportunity to explore and evaluate if actually it's just increasing efficiency. I've made the test, I've made the diagnosis, so I'm not going to continue to see you back and back again. But it's a 7% decrease in 3 months. So when we look at actually, were we able to save costs? Yes. Overall, the PMPM, so that's the per member per month total cost of care, decreased by $266. 3 month time that was followed over 3 months, almost $800 per member cost savings. So it is less expensive care. Diving into why it's less expensive is actually that publication is being worked on now, but ostensibly it could be decreased repetition of labs. It could be decreased frequency visiting the medical home. There's a lot of different opportunities to be able to tease out exactly what leads to that cost saving. Our specialists are getting paid. There's an opportunity for primary care to get paid. The truth is, and this goes back to CMS guidelines, it is the way that they've offered payment to place an e-consult. So the diagnosis code is a 99452 is $37. But you have to document that greater than 16 minutes spent on preparation of that e-consult. So again, they want to fund you for communication, which is great. But if you have a 20-minute visit, spending 16 minutes typing up an e-consult and consenting a patient for the e-consult, it's not practical. And so we actually see very, very few primary care providers dropping that code. Specialists, we actually just need to document that we spend more than 5 minutes. Now, one of the important things that I think that has been buried in previous talks is that when we look at the conversion rate, so I've reviewed your data and I said, no, I think that patient needs to come in and I'm going to get them booked into clinic. Not only are they seen sooner, but their no-show rate goes from our average, which is around 12% in the institution, down to a 4% no-show rate. So if you book in that patient, that slot's going to be used much more likely than an average referral. So, as I said, for the patient experience, you have a decrease in wait times on average by 8 days for a converted e-consult. So if I say you need to be seen in clinic, you're going to be seen sooner by 8 days on average. There's also a supply side multiplier, which means that if we do, again, across pediatrics and adult, we've done 33,000 plus. We have a 76 completion rate. That means that there's 25,000 patients with care transition averted. That would be on your average template. Providers book them in for somewhere between 40 and 60 minutes. If we just say 60 minutes, that's 25,000 hours of specialty care that was actually maintained in the primary medical home, which increased access for all patients with demonstrable need. Decreased travel costs. And so we actually looked from July 2018 to December 2022. We looked at 11,000 completed consults. There was almost 500,000 miles saved in travel, which related to 8,000 hours of travel time. And if you look across, just if you assume minimum wage of $15, that's $125,000 that were saved just by the act of putting in the e-consult instead of driving to the campus. And that's $91,000 in gas saving, 21 gallons. And again, I'm a greenie, so we looked at, again, what was our savings in terms of environmental impact, but that also fits in under the AAA under community impact. 2,005 metric tons of carbon dioxide saved by just doing your e-consult. Be a good citizen. Now, on average, each per capita emission, Americans per capita put out 14 metric tons per year. And so that's about 14 patients or 14 individuals never driving their car for a year or producing any CO2. I think that's pretty cool. I'm not sure that's, it's not going to save the polar bears, but it's cool. It's a little step. The last thing I want to highlight also is that care maintained in the primary medical home. There are resources in the primary medical home that I don't have in my clinic here. We have translators and interpreters, which is absolutely fantastic. Social work is challenging. CHOWs or community health workers, we don't have. And so when you think about having your care in a local community clinic, there are cultural issues that are better met in a community clinic than coming to see me here. And so there could be, and it has to be studied, potential benefits and decreased cultural barriers to care and increased wraparound to community services that are available by maintaining care in the primary medical home. So, and the last thing on e-consults I'll leave you with is that if you do e-consults, people might die less. And this was actually an article out of Mayo Clinic. And so they looked at 2 rural hospitals associated with the Mayo system, looking only at ID e-consults. And what they found is that compared to a propensity match control, and it was a 1 to 2 match, sorry, 1 to 3 match, I can do my math. When they found that at 30 days post-discharge, if an e-consult was placed to ID for an infectious problem, that there was a significant decrease in 30-day mortality. That's important. Placing an e-consult actually made less people or aided in or could be causal to having less people die within 30 days post-discharge. So ECHO is the next piece. And I'm doing okay for time. So ECHO, again, this is the synchronous model, which is video assisted. We all sit down. There's a didactic provided. There's opportunity for case review. But as opposed to being a 1-to-1 peer relationship, this is a 1-to-20 peer relationship, a 1-to-10 relationship if you're, depending on what specialty you're in. But not only is there then fostered collaboration among your groups, but you can actually bring in multidisciplinary panels. So in the initial ECHO, Hep C out of New Mexico, they would impanel. And again, this was looking at hepatitis C treatment in the interferon ribavirin days. So it's not this DAA that we're using now that is a little bit easier to use than the interferon days. But they would impanel a behavioral health worker, pharmacist, a hepatologist, an infectious disease doctor. multiple partners out in the community. And again, they create a cohort themselves and can share experiences, and they present cases, which then help educate other members of the cohort. And then when you look at the force multiplier effect, each of them have a panel. And so again, if your primary care doctor has 3,000 patients and you're training one person to do something better, that multiplying effect is actually much bigger than you ever anticipate. So ECHO was started in the University of New Mexico. It is now global. We joined our ECHO program in 2013. There are now over 4,600 different programs in over 191 countries. So widely adopted. But again, these are, each program, each group has their own flavor, how they do it. They have their own topics that they cover, and no one ECHO does everything. So at the beginning, I said, I want to show value. I want to put this in the context of value. And this is challenging. I was able, I think, to make a good case from our existing data that there is value in terms of patient experience, provider experience, possibly decreasing cost of care. Or I'd say we do decrease the cost of care. Value in ECHO has been more challenging. In fact, there are a total number of publications that relate to ECHO programs are 287. And if you apply the Moore's level of evaluation, so basically saying how strenuous are you looking to actually see a change in provider behavior or in patient outcomes, level 1 and level 2 are quantitative and qualitative, mainly looking at utilization patterns. We have that dialed in. Every program that we do, we have that data. We show on Likert scales that people enjoy the experience, they learn, so we get to Moore's level 3 and 4. Self-reported efficacy, knowledge or confidence, objective pre and post knowledge, we have all that down. And again, we fit in with, there have been a lot of publications about that. Again, when you look around the case uses, there's still opportunities in specific case uses where things have not been published. But really, to be able to say we're changing value, you have to look at level 5 and level 6. Have you changed participant behavior or performance? And that's looking at like drug utilization, clinic or hospital orders. Have you actually created clinical outcomes or improved patient health, level 6? And that's where there, again, is a little bit more publication. And then in terms of total cost of care, there have been 3. So out of 287, that's a little bit scarce, but I think that there's enough out there. And to highlight some of these, the initial publication in 2011, it was a New England Journal of Medicine publication looking at the University of New Mexico experience in Hep C management. Again, to reiterate, this is the interferon days. It was much harder. And what they found was non-inferiority. They had 21 spoke clinics presenting, 800 patients, and what they found is that there was no statistical difference in between the community sites and the University of New Mexico HCV clinic when it came to sustained virologic response. And actually, those numbers were better than most numbers that were being published at that time, looking at sustained virologic response for type 1. So this model actually was beating other public data. You can't compare, but actually saying non-inferiority, absolutely. And the SAEs were statistically the same, but there's a trend to favor care in the home community. They were actually seeing more of the adverse events earlier and theoretically addressing those. Subsequently, there's also been a look at direct antiviral treatment in areas with low specialist density. And what they found was that for every 100 providers that have been trained in different Hep C echoes, and they're mainly looking at the New Mexico, and again, the New Mexico model is available nationally. There are other homegrown programs that are more local. We've done one out of Denver Health that was wonderfully successful. And when we actually did it with, this was early on in the DAA transition, when we first did it, HICPUF, who used to would only allow prescribing for patients with established relationship with hepatologist or infectious disease doctor, eventually actually started approving prescription of direct acting antivirals to PCPs that have participated in ECHO. So we're actually able to leverage our work to open up care for populations that were not able to prescribe previously. But what we know is that for every 100 providers, there's a significant increase, a 9% increase in the likelihood that a patient with Hep C is going to be treated. And when you look at the outcomes for Hep C, that has both economic and humanistic improvements. So a change in patient health as well was demonstrated through something that, this is a program that was done out of Beth Israel, and it was called the ECHO-H pilot. And so they did an 18-month program training, and it was paneled a geriatrician, a geropsychiatrist, and a neurologist on how to more effectively manage delirium and combative behavior. And this is, again, almost too good to believe, but it's true. They found that if you were looking at one of the programs that participated versus propensity-controlled groups that did not engage in the echo, they found a 75% decrease in physical restraints. That is massive. 17% less likely to be prescribed an antipsychotic medication. Did not reach statistical significance, but that's still important. So we've also shown it that providers, and this was Dr. Frank over at the VA, looking at if you did scan echo pain, you were more likely to leverage physical medicine services as opposed to prescribing an opioid, as well as using non-opioid pain management. Another group in Cleveland showed a 15% decrease in prescription of opioids by providers that went through echo scan pain. So what are we doing locally? Well, 2023, we ran 39 different series. So those are different topics that included 282 sessions for almost 3,000 participants. Participants have come from 54 of the 64 counties in Colorado. So we have a massive reach. And this is one of the greatest. I love this slide because, again, it's taking the good work for people that are smarter than me, that trained me, and actually amplifying it across Colorado. When we look at it, we're also getting into the spaces where we're needed the most. 61% of the participants reported that they take care of Medicaid population, 20% of the rural and frontier communities. And now you have to remember that of the workforce that we have, it's only about 2 to 4% work in a rural community. So that's actually big overrepresentation, and then 54% report working in a medically underserved community. Echo series that we ran in the last year, and this is not the complete list. There's a lot of topics that are going on and a lot of important work that's happening. Variable participation. Typically, we have average participation per session being 30. Some of these, again, there's not a lot, but having one person learn about autism in Durango and managing that patient there has a huge benefit to that family, and also how we do our economics. This is only a small sampling of the things we've done over the last, since 2014 when we first launched. Now, I want to apply this back to that earlier map that we talked about in terms of rheumatology and why I find this important. So if you look at our current density of rheumatologists in Colorado, we have a bunch in the Front Range. There is nobody over on the Eastern Plains. There's a couple scattering over here on the Western Slope. There's 2 down in Durango. That's it. Now, by e-consults, we're available throughout the state. Through Echo, we're available in other parts of the state where we don't have that electronic bridge between our EHRs. Is it complete? Absolutely not. There's still a ton more work to do, but this is important. So in summary, and this is a long slide, so I think that I've fulfilled the promise that I could put this into a value context on how the idea of doing what we've been doing for decades, communicating, collaborating, discussing, level setting, working to wrap around a patient and give them their care. And now we're just doing it electronically, so we can actually increase the footprint of the good work we do on this campus. I'd like to thank again our executive leadership, Ann Fulbrigge, my boss over at the PMCC, Fred Thomas, and then this is the PMCC staff, past and present. I do want to highlight Mike and Dave Saxon. They've been long suffering. Every time I've come up with a pilot, they've jumped in with both feet. They're wonderful human beings, and they're not afraid to tell me when I'm wrong and when I need to address something. As Kyle Leggett has also been he's in the Department of Family Medicine. He has been our go-to COVID guy since the beginning of the pandemic. We had sessions during the pandemic that were running 3 times a week, every morning, and having 200, 300 participants, just trying to figure out how we're going to get through it together. And he was masterful in that role. And the rest of our staff, and a special call out for Matt Thompson, who again did most of the legwork to develop our eConsult program here. He's now somewhere over in the UC Health. Maybe he's watching, I don't know. That's what I have. Thank you.
Dr. Pearson, that was excellent. Thank you all. Open up for questions to the live audience here. While we're waiting for a few hands to go up, quick question. How do you advertise this? So how do providers out in rural and frontier areas know that you exist?
So for eConsult, because it requires electronic bridge, we don't advertise it. We work specifically with clinic leadership. So Peak Vista development would have been an example where we look at referral patterns to clinics. We find out where there is high utilization, but maybe not the right utilization. And as a group, we've reached out and found good partners in those groups to be able to then launch and develop that electronic bridge. It does require an investment from those groups because, again, they need their IT aligned, they need their leadership aligned. And then we typically take on the education of their providers in partnership with that group that runs the single sign-on web app. For Echo, we actually have over 8,000 previous enrollees. We increased our roles markedly over the whole COVID period, and we've been in 46 states. So we have a pretty robust organic outreach, and it continues to grow. And sometimes we advertise through other Echo groups as well. Some of the programs are doing it collaboratively. But once you end up getting an email from us, we kind of continue to send emails. Yeah, Devin. Oh, sorry, he's gonna.
Oh, yeah, I got you.
Thanks, Duane. Great talk. What's your vision of how the data, especially around the e-consults, is going to change practice? I think now a primary care can ask that it be an e-consult versus just a regular referral. Will this, I can use the term, force all new referrals to go to e-consult first and then be determined if it should be inpatient or outpatient, and just basically change the practice flow? Because I think right now I'm having a hard time seeing how this is really stop the number of new patients coming to clinic. If this is really viable, is that something we're going to do in the future, force e-consults?
Well, let me flip around a little bit of the language you used at the end. The goal is not to stop new patients from coming to clinic, but is to enhance the patients that are coming, focusing again on having the right patient, getting the right level of care, that idea of right sizing care. And that again, if I'm not going to be able to help you in clinic, then maybe seeing me in clinic isn't the right level of care for you. You've invested time, you've invested a drive. But going back to your question about this, there have been programs where they do turn off the referral network and everything goes through eConsult. They did that at the University of Connecticut, and the entire LA community health system based out of USC is now, there are no referrals, it is only eConsult. And the clinics are filled with people that have gone through eConsults and been converted to an on-site care. I think that, again, that is way above my pay grade, and there needs to be a lot of discussion. I think a better model would be to figure out ways, I like the carrot more than the stick, but to actually figure out that if you have been screened by or triaged by an e-consultant and said, I think this person needs care, building out a system where that person can get in sooner, again, I think is ethically better than just saying, no, I'm going to take you as a primary care physician and force you to do an e-consult. I think having differential access, again, is above my pay grade, and that's something that would have to be explored. And I think that it can only be done in a collaborative pattern with primary care, because they are a significant part. If we really are talking about enabling the primary medical home, it really is about having this be a collaborative decision and not just shutting down the walls.
Dr. Stenya.
Duane, thanks. You and I share this passion, so thanks for the presentation. One of the challenges clearly is operationalize e-consults on the specialist side of things. How best do you think, or in your opinion, how best to operationalize this? Do we embed time in templates for e-consults? Do we allow them to do half days of e-consults? Is this something we ask them to do above and beyond? Opine a little bit on what you think is the best strategy for that.
You're trying to get me pilloried up here.
Yeah.
Everybody should do more. No, I think it's a volume and productivity measure, and we have the right pieces to solve that problem. If you have the majority of your e-consultants completing an e-consultant within 10 minutes, that gives you, again, what time and availability should be. But I also think that, again, if the volume in your clinic or your numbers aren't that high, trying to carve out time is probably inappropriate. Creating a way to actually have revenue sharing from whatever revenue comes from that, it should probably be the first carrot to try to get people in the e-consultant pool. I think the next step, though, if you're seeing volumes where, again, you cannot continue to do it on the shoulder time because we have to be very respectful of that. That is when you can actually look again and say, well, how many RVUs are these people typically generating per half day? What would an RVU from an e-consult is 0.7? And so how many RVUs, if you were to block out a half day, what does that look like? And again, that's math and money, and it's absolutely possible. And I think that that is the best way to try to actually not change it so it's more, but actually just change the work duties in a way that you're being respectful to your providers. The last piece of it I want to highlight, though, is that this requires zero space. This is from home. This is in the antrim of Vinit's office. That's where I like to do all my typing. Why are you here again? And why are you wearing shorts? Again, this requires no space. And so if you can continue to grow the volume and then get people doing this in the off-site, away from clinical operations, I think that that is the next wave of growth that we can look at. And then how we leverage that in terms of clinic access, I think is, again, I would much rather look at a carrot, which says, hey, if we think you need on-site services, we're going to get you in quickly. Because the other part of that is it's a collaborative approach with a primary care provider. That patient is then informed, hey, we need to see you on site. And then the specialist is seeing them. It decreases moral jeopardy. It decreases that sense of, why are you here? It's actually, oh, I know exactly why you're here. I know what the data is. And a lot of times you actually already have your plan laid out before you lay hands on the patient. And then you're just there validating what the initial impression was. Thanks, Eddie.
Dr. Hager?
Thanks again, Duane. That was really a great talk, and I really appreciate your leadership in the PMCC here. It's been fantastic. I want to follow up on what Kevin said, because you said there have been practices that have done this, trying to funnel to e-consults and then see which ones should be converted to real consults, and not so much a carrot and a stick, but just to see a flow pattern. Do you know if there's any data from those places that have been doing kind of e-consult first, as far as satisfaction, outcomes? You know, is that a model that looks like it could be sustainable?
So the guy that helped the LA system set up, his name's Hal Chen, and he is one of the grandfathers of e-consult. He was at UCSF at the beginning, and then now is working for the county system in LA. The only published data they put out was a provider satisfaction essay on primary care. Their satisfaction scores were lower than what we've seen here and in other publications. And there's a higher rate of a sense of just worse task shifting by their primary care panel. But it is a place, again, where it is ripe and open for further research. But I also think validation studies need to happen, just like Marisha did with curbsides. That ability to be able to actually go out and look at patients that we've put into the primary or maintained in the primary medical home and say, okay, well, what do their outcomes look like a year or two from now? Like we did in our initial triage paper. That needs to still be done, and that's a great opportunity. But again, that's really going to require academic workforce from across the divisions, because you need somebody that has a broad knowledge across each of these case uses to be able to study that and look for appropriateness. There's a lot more work to be done.
I know we have a number of outstanding questions, but I think we're right at 1 o'clock, so we'll have to cut them off. I apologize, but Duane, thank you very much for this talk.
Thank you. Thank you all.